Good good evening, folks. This evening's topic D is a bonus one. It's talking about reversing diabetes naturally. I've done a little narrative to help illustrate the points in the presentation. So please enjoy. Okay, here we go. Harold didn't think of himself as sick. He thought of himself as older. There's a difference, though people rarely name it. When his doctor told him he had type 2 diabetes, he nodded politely, the way older adults often do when confronted with a new diagnosis. He tucked the paper with his lab results into the inside pocket of his jacket and went home to make tea. The maple tree outside his kitchen window rustled in the wind, its branches steady and unbothered. He wished he felt the same. He followed instructions. He took the metformin. He walked more. He cut back on his sweets. But he also felt himself shrinking, not in size, but in presence. His appetite faded. His legs weakened. His world narrowed to the radius of his fatigue. It wasn't until a younger clinician asked, "Harold, do you feel strong?" that he realized strength was part of the story. That diabetes wasn't just about glucose. It was also about agency, about whether he could still carry groceries, walk to the creek, or trust his own body. His path to remission wasn't dramatic. It was a series of small, steady pivots. A Mediterranean breakfast, a slow walk after dinner, a lightweight lift, a lightweight lifted twice a week. The fog lifted. The number fell. His body remembered his way back. Marisol, the clinician who knows the quiet work. Marisol had been practicing medicine long enough to know that remission was possible, but not common. Not because the psychology was complicated, though it was, but because the story was complicated. Patients didn't just carry glucose, they carried grief, caregiving, and night shifts, loneliness, food deserts, and the exhaustion of being responsible for everyone but themselves. Diabetes was often final expression of years spent running on fumes. He had learned that that the most powerful intervention wasn't medication, it was a question. What do you want your body to be able to do? Some said they wanted to kneel on the garden again. Some wanted to dance at their granddaughter's wedding. Some wanted to sleep through the night without thirst waking them. Some wanted to feel hunger and fullness like normal people do. Mirasol built plans around these answers, not around numbers. She used low energy diets when someone needed a metabolic reset. She used low carb approaches when post meal spikes ruled the day. She used Mediterranean patterns when sustainability mattered more than speed. She watched people reclaim themselves, not perfectly, not permanently, but meaningfully. Remission, she realized, was not a cure, it was a return. The body, a voice we rarely hear. If the body could speak, it would say, I've been trying to protect you. It would say, I stored fat because you were stressed, because you were tired, because you fed me what was available, not what was nourishing. It would say, I resisted insulin because I was overwhelmed, not because I was broken. And when remission begins, when weight falls, when movement returns, when food becomes fuel instead of coping, the body would say, thank you for listening. The liver releases fat. The pancreas breathes. The muscles pull glucose without insulin. The fog thins. The numbers soften. This is not magic. It's biology, but biology has always been a kind of poetry, a system of remembering, repairing, and returning. The body does not demand perfection. It asks for consistency. It asks for gentleness. It asks for the kind of attention we give to things we want to keep. The braid. 3 stories, 1 truth. Harold's quiet determination. Marisol's steady guidance. The body's whispered resilience. Together they form a single truth. Type 2 diabetes can move to remission when the human story is honored alongside the metabolic one. Remission is not a finish line, it is a threshold, a doorway back into a life that feels more spacious, more possible, more one's own. It is the work of returning slowly, steadily, bravely to the body that has been waiting. Okay, here, guys, second part of D is a clinical policy hybrid essay on diabetes remission. Okay, so here we go. The work of returning, a clinical policy hybrid essay on type 2 diabetes remission. The clinical truth: remission is possible, but not accidental. In exam rooms across Northwest Pennsylvania, clinicians see the same pattern unfold. A patient arrives with fatigue, elevated glucose, creeping A1C, and they sense that their body has slipped out of its own rhythm. They are not surprised by the diagnosis. They are surprised by how inevitable it feels. Yet the physiology tells a different story. Type 2 diabetes is not a one-way progression. It is a metabolic state that can be reversed, not cured, but returned to normal function through sustained changes in weight, diet, movement, sleep, and stress. The evidence is unequivocal. Substantial weight loss, 10 to 15%, is the strongest predictor of remission. The low energy diets rapidly reduce liver and fat and normalize fasting glucose. Low carb approaches lower insulin demand and post meal spikes. Mediterranean patterns improve inflammation and long term sustainability. Physical activity acts as a metabolic multiplier independent of weight loss. These are not fragile interventions, they are supported by randomized trials, primary care linked programs, and international guidelines. They are the backbone of lifestyle driven remission. But clinical possibility is not the same as clinical reality. The policy truth: our systems are built for management, not remission. Health systems, including the ones you help lead, are structurally oriented toward chronic disease management, not reversal, not remission, not metabolic restoration. The incentives are clear: free for service, fee for service, rewards visits, not outcomes. Nutrition counseling is increasingly reimbursed. Intensive lifestyle programs are soloed or grant dependent. Primary care is overloaded and under resourced. Community supports are fragmented. Social detriments are acknowledged but rarely operationalized. Patients are told to eat better and exercise more, but the system does not scaffold these behaviors. It does not provide the structured, low energy programs that produce remission. It does not integrate resistance training into routine care. It does not fund Mediterranean pattern nutrition education at scale. We have built a care model that treats diabetes as a permanent identify rather than a reversible condition. This is not a clinical failure. It is a policy design flaw. The human truth: remission requires a story patients can see themselves in. Patients do not change because of data, they change because of meaning. Harold, the retired machinist, did not pursue remission because his A1C was 8.2. He pursued remission because he wanted to walk the creek again without stopping to catch his breath. Marisol, the clinician, did not motivate her patients with risk ratios. She motivated them with questions that restored agency. What do you want your body to be able to do? Patients need a narrative that frames remission as a return to strength, a reclaiming of energy, a restoration of metabolic trust, a possibility available to them, not just to other people. Policy must support this narrative. Clinical practice must embody it. Community infrastructure must sustain it. The system we need a remission oriented model of care. A health system serious about diabetes, a remission would redesign care around 5 pillars. Early identification of remission candidates, use EHR embodied algorithms to flag patients with high remission potential. Recent diagnosis, preserve beta cell function and modifiable risk factors. This shifts remission from patient inherited to clinical or clinician offered. Structured lifestyle programs as standard care, not optional, not peripheral, covered, integrated, and tracked. Programs would include low energy diet pathways, low carb therapeutic nutrition, Mediterranean pattern coaching, and resistance and aerobic training, sleep and stress interventions, medication uh, de-intensification protocol, workforce training and metabolic counseling. Primary care clinicians need training in motivational interviewing, nutrition literacy, exercise prescription, medication tapering during remission. Social detriment navigation. This is not extra, it is core competency. Community partnerships. Remission cannot happen in clinic alone, it requires grocery store collaborations, YMCA and senior center exercise access, food medicine programs, peer support networks, transportation solutions, payment reform, shift reimbursement toward remission rates. Weight loss milestones, medication de-intensification, sustained metabolic improvement, team-based care. This aligns financial incentives with biological reality. The future truth, remission as a public health imperative. If remission were treated as a population level goal, not an individual achievement, the impact would be profound. Reduce cardiovascular events, lower medication burden, improved workforce participation. decreased long-term care dependency, low health system costs, increased healthy longevity. Remission is not a boutique intervention. It is a public health strategy hiding in plain sight, and it is of the few one of the few strategies that gives patients something rare in chronic disease care, hope grounded in psychology, the braided clinical possibility, policy reality, human meaning. When these three standards are woven together, the clinical, the policy, the human, remission becomes not just possible but probable. Okay, guys, that's your shows for today. I'll be back on Monday for shows, or if I feel like it, maybe tomorrow. We'll see what happens. For now, Gator Wellness. Take care, folks.